Thank you, Jared. That was great. It gives me great pleasure to introduce my co-moderator, Dr. Owen Obel. Owen is an associate professor at UT Southwestern. He's the director of the electrophysiology lab at the VA, an effort he's led with considerable grace and expertise. And he will be speaking to us today about atrial fibrillation and anticoagulation strategies. Owen?
Let's go back up to my first slide there. Okay, you've seen all my slides, so there we go. Any questions? Okay, it's my pleasure to be presenting here today. I'm always grateful to Subash and Manos for inviting me to talk at this symposium, which I always enjoy, even though I never see a single electrogram while I'm here. Somehow still manage to enjoy the conference very much, and glad to see it growing year by year and to be a part of it. I have no disclosures relevant to this talk. In the next few minutes, I'm very, very briefly going to run through some points about anticoagulation in atrial fibrillation, where we stand today in 2015. I know that the audience here are well aware of the fact that Coumadin, the dose-adjusted range between 2, well above 2, between 2 and 3.5, results in a marked reduction in the risk of stroke, to the point where if the dose is kept with an INR of above 2, the rate of stroke is similar to patients in sinus rhythm. So I know that everybody here knows that. That's a given. I just want to make a few points. The first point is that in addition to being the commonest cause of ischemic stroke and the most preventable cause of ischemic stroke, atrial fibrillation actually results in strokes which are more severe than any other strokes. This is no matter how you gauge it. If you look at survival after stroke, it's worse in your atrial fibrillation-associated strokes. If you look at your disability, it's worse after your atrial fibrillation-associated strokes. If you look at recurrence of stroke, it's worse after atrial fibrillation-associated strokes unanticoagulated. So I want to make it clear that this is a major problem. The strokes that result from atrial fibrillation result from sudden vessel occlusion without prior collateralization and often result in hemiplegias, aphasias, and lifelong severe deficits. The other point I'd like to quickly get to before we come to the anticoagulation aspect is that aspirin and clopidogrel simply don't work. We know from the study, which was the Active W study, which was actually stopped early because you can see there was a marked reduction in mortality in Coumadin. This was Coumadin compared to clopidogrel and aspirin. So I want you to get it immediately out of your minds that anything that inhibits the platelet doesn't really do anything to the risk of stroke in atrial fibrillation. The reductions that you do see as a result of antiplatelet drugs probably result as a reduction of cerebrovascular disease-mediated strokes in people who happen to have incident atrial fibrillation. If you do have a patient who cannot take anticoagulants in the form of NOACs or Coumadin, then clopidogrel, in addition to aspirin, is slightly better. The reason for this is as our understanding of the pathogenesis of stroke and atrial fibrillation is that this should be seen as something similar, in my mind, to a DVT, because it results as a result of low flow situation with not that much damage to the vessel wall in most cases, at least in the early phases. This is unlike an arterial type stroke event, which occurs with rupture of the endothelium and recruitment of platelets. This is rather sluggish flow, and in fact, although we know that the left atrium is part of the arterial circulation, in the case of atrial fibrillation, many parts of the atrial fibrillation actually operate according to something similar to a venous circulation. That's why, like a DVT doesn't respond to aspirin, PE doesn't respond to antiplatelets, neither does thromboprophylaxis. This is the culprit of at least 90% of ischemic strokes, thrombus forming in the left atrial appendage, and this is a thrombotic event. It's not a platelet-mediated event. Platelet recruitment into the thrombus is late. What we really have is thrombin, and thrombin causes fibrin to link arms and form a thrombus. So, if there's one slide I want you to remember, it's the entire details of this, okay? Just kidding. Just very simply going to this, how does Coumadin work? Because that's the drug we're going to start with. Coumadin is vitamin K dependent clotting factors, so it actually affects the extrinsic and intrinsic system. 2, 7, 9, and 10 are the clotting factors which are affected by Coumadin, 2 being the final common pathway which leads to the generation of thrombin, which is critical in the development of cross-linked fibrin polymer, which is another name for a clot or thrombus. So I'm not going to go over the Coumadin trials because I'm going to assume that everybody here knows the Coumadin trials. I just want to come on to something about risk assessment. For many years we've used the CHADS-2 score. That was a score which was developed from the major trials of anticoagulation with Coumadin against aspirin and took the risk of stroke in patients in either the aspirin or placebo arm, looked at a variety of factors. This has since been refined with what's known as the CHADS-VASc score. The CHADS-VASc now actually has age as a trichotomous variable with 0 less than 65, a score of 1 between 65 and 74, and actually a score of 2. So that's useful. Also, women have a high incidence of stroke associated with atrial fibrillation, so they now get 1 point, and vascular disease as well. If you look at the risk of stroke across the different CHADS-VASc categories, you can see that if you've got a score, say up here, of 7, the annual risk of ischemic stroke is extremely high, around 10. The important thing is that the CHADS-VASc helps us over the CHADS-2 in that it tells us what to do with our patients who are in this moderate risk. There were many patients who were at very low risk in the CHADS score who were getting stroke. With the CHADS-VASc score, it gives us more of an opportunity to split out those patients. Something that you're probably all aware of now is we're also now using the HAS-BLED score, which is a risk of bleeding associated with the therapy, which is, of course, the major problem associated with the therapy. We know that the best therapeutic range is between 2 and about 3.5. The risk of stroke precipitously rises with the INR below 2. So we recommend a target dose of at least 2.5 for our patients with Coumadin. Moving on to the NOACs, the first NOAC, by the way, I've just been using this term, novel oral anticoagulating agents, novel oral anticoagulants. So the first one that came out, as a lot of you guys know, the dabigatran directly affects thrombin. Going to very, very quickly go through the slides. There were 2 different doses of dabigatran used in the RELY trial, 150, 110, compared to Coumadin. This was a non-inferiority trial. All the trials which have been performed are non-inferiority. Some have had superiority tacked onto them, but this was strictly a non-inferior trial. So just to see if it was non-inferior to Coumadin, it achieved that primary endpoint, both in terms of bleeding and in terms of stroke reduction. Both doses achieved that endpoint. What was interesting and what has held true across all the anticoagulation trials of the NOACs is that in addition to a reduction in ischemic stroke, there is a marked reduction in hemorrhagic stroke. This is partly and likely due to the fact that you don't get these wild swings in anticoagulation in these people, and probably also that some of these hemorrhagic strokes are actually infarcts which have undergone hemorrhagic transformation. Moving on to the other NOACs. 3 of them, rivaroxaban, apixaban, and edoxaban, all are direct factor 10A inhibitors. This is the same molecule that drugs like Lovenox, etc. work on. So I'm going to quickly flip through these 3 trials. This was the ROCKET AF trial. It was a non-inferiority trial which compared rivaroxaban to Coumadin and showed that rivaroxaban was non-inferior to Coumadin in the reduction of stroke, with a reduction in major bleeding events, including intracerebral bleeding events, very similar to RELY. You're going to see a pattern here. These are not difficult slides to look at because they all show the same thing. This was apixaban, the Aristotle trial. Okay? I know Manos likes this a lot because Aristotle's a Greek name, but then again, all the dronedarone trials were Greek names, and that was a terrible drug. Sorry, Manos. Just kidding. So this drug, actually, its primary endpoint, like RELY and like ROCKET AF, was a non-inferiority, but the secondary endpoint was, in fact, superiority. And so this drug actually was the first to show superiority over Coumadin, both in reduction of ischemic events, that's ischemic stroke or thromboembolism, and a reduction in bleeding. So we're getting this consistent pattern across the trials. They're non-inferior or superior to Coumadin in the reduction of strokes, but we also have a reduced bleeding with the one caveat that there is a slightly increased risk specifically of gastrointestinal bleeds. But the bleeds that we hate the most, intracerebral bleeds, interestingly, are reduced by all of these drugs. And that's all I wanted to say about that. So you can go through each of those drugs and pick your poison. Basically, at this point, what you're picking is, am I going to go for Coumadin in this patient, or am I going to go for one of the NOACs? There's some to choose between them, but not that much at the present time. Just my concluding slide, just a few points about this. We know that AF is a very important cause of stroke. We know that both dose-adjusted Coumadin with an INR of above 2 or one of the NOAC agents will prevent stroke in this condition. But they are novel, okay? They're still called NOACs. One day they'll be called OACs, okay? But at the moment, they're still NOACs, okay? So they're novel drugs. So we're still learning how to use them. We're still learning how to deal with patients who come in with major bleeding on these drugs. We're still learning how to cardiovert people on these drugs. We're still learning how to do AF ablations with people on these drugs. How to reverse these agents and how to bridge with these agents is still a work in progress. Triple therapy remains a challenge, whether you choose Coumadin or a NOAC. We're trying to avoid it at this point. Certainly, if you have a patient on triple therapy, please consult someone in this area. You consult your interventionist and say, can I drop one of those? Can I please either drop the aspirin or can I drop the Plavix or other antiplatelet agent? But triple therapy is to be avoided, and I think we all agree with that. And really, we're looking at optimal bridging strategies, and I said, but really the key of this talk is whoever finds, the drug that reverses these NOACs is going to be the winner out of the NOACs. Turns out that the reversal agent will probably work for all four. Thanks for your attention.